Well, actually, what we did, and we started on March 8th, was that we instituted a pre-triage desk at the entrance of our day hospital. So where patients are coming to get their treatments or to get their first-time visit or follow-up or on treatment visits. In this pre-triage, we measure temperature and we ask for contacts, if the patients had some contacts. This with positive people. This pre-triage was actually preceded by a phone call on the day before, just to avoid that symptomatic patients with suspicious COVID disease could come to the day hospital. And we refer these patients to their treating physician at home, to the medical doctors, general practitioners at home. Once in the hospitals, actually in the day clinic, we basically maintained all treatments in patients, with the possible exceptions of some treatments in very advanced disease stages, where you administer active treatments, but you might also achieve the same benefits with palliative care. So all these patients were temporarily or permanently referred to palliative care facilities, or again here in the hospitals. We used to perform active chemotherapy basically in all patients. So all patients were maintained on the treatment they had, and all new patients started treatment as usual. So we had no delay. As far as follow-up visits are concerned, we basically avoided to have patients in the hospital. So all NED patients, especially in case of breast and colon cancer, colorectal cancer, we did follow-up visit by phone or by Skype, or by the patient sent us email with all the diagnostics that they did, that they performed, and we performed visits online. And then we avoided to have strict follow-up. For instance, we avoided the patients to go in the radiation settings to get CT scan or whatever, because they could get COVID there, because it was not always clean what the patients has to do and where she or he had to move to get their diagnostics to be performed. All the screening, mammography and colorectal screening was stopped in Italy and is not yet resumed actually. And we admitted to the day hospital only those patients who really require to be seen by the doctors, since they were symptomatic for their oncological disease, for cancer, not for COVID. In all our patients in follow-up, and actually the patients like this. I mean, they don't suffer from not being able to come in the hospital, and especially breast cancer patients, they acknowledge that this was done only to protect patients. And actually for some patients who were on oral drugs, they wanted to postpone the visit to the hospital to get the drugs. So we are giving more pills, more drugs to the patients, so that they can stay at home, take their pills, and just call in case of problems.
Perfect.
Well, the extra complication is in case of patients who are positive to COVID. In that case, if the patient is symptomatic, there's nothing that can be done. The patient has to stay or at home or in hospital, and our patients have higher risk of getting COVID, actually, because they're frail in any case, and because the status of cancer actually produce a status of pro-inflammation in the body that leads to a prothrombotic state. So all the complications for a symptomatic COVID infection are extremely important in cancer patients. And actually, we had some cancer patients that died from COVID. We should not abandon our COVID positive patients, because many oncologists are saying is that if the patient is COVID positive, we don't want the patient, there is nothing that we can do. Actually, if the patient is symptomatic, it's very easy. They have in any case to follow the COVID course, with drugs, they can be admitted in the hospital or whatever. If the COVID positive patient is totally asymptomatic and never has symptoms, you have two options. Or you wait that the patient becomes again COVID negative, but this is not so easy, and it does not happen so often in cancer patients. They stay COVID positive for a few months in our experience, and there you have to decide what to do. If you have a triple negative early breast cancer patient and the patient is asymptomatic, but the swab is still positive, we treat these patients actually. And we treat with regular treatment, which is chemotherapy. So if the intent is curative, as in the adjuvant setting, but also in the first line metastatic setting, if the patient is HER2 positive, we treat patients. We go on with chemotherapy, because and also with anti-HER2 treatments. We try to avoid those drugs that are complicated by interstitial pneumonia, and we have a few, paclitaxel, lapatinib, for instance. But we use chemo, and we use all the treatments in this type of patient. All the patients that had higher risk of getting COVID disease, as we know, and also of dying from COVID disease. This is especially because they have a number of comorbidities due to increasing age. So what we do, we try to avoid these patients to come to the hospital for visits, follow-up, even in case they need follow-up or they need to be checked during treatment. And we try to prolong the period between two subsequent treatments. But we have two things that we must take into account. First of all, at least in Italy, we test for COVID only symptomatic patients. We don't test asymptomatic patients. And given the spread of this disease and the fact that cancer patients have a higher probability of becoming COVID positive, we assume that we are treating a number of COVID positive asymptomatic patients, and we do not know because we do not screen. This is the first point. The second issue is that what could happen is that there is a recrudescence of the viral infection, even in the asymptomatic patients, a sort of reinfection. But this was only sporadically demonstrated for hepatitis B in the liver. But here we do not know actually. What we want to do now is to measure the viral load in the blood of these patients to understand if they have a high viral load or a low viral load, and to measure also the speed, the replication rate of the virus in the blood in these patients that undergo active cancer treatments. But as of now, we had no problems. I know from some other colleagues that they also performed the high-dose chemotherapy, for instance, in young boys with seminoma cancer. And also radiotherapy. We are also treating a patient that has gastric cancer with a combination of radiotherapy and chemotherapy. So in our opinion, COVID positivity in the asymptomatic patients must not be a reason not to give treatment. if the treatment has a curative impact. Well, the potential consequences of delayed treatment is that if you have aggressive disease and you don't start at all because the patient is COVID positive, you might miss the opportunity to cure the patient. If the disease is progressing and you don't give treatment, actually you might have an impact on the chance of life of that patient. Let's think about aggressive triple negative disease. If you don't treat, even in the adjuvant setting, you actually put some problems on that patient that might be heavier than the problem induced by an asymptomatic COVID infection. But the same is also in advanced disease, because today we can manage metastatic breast cancer patients for many years, especially in the case of HER2 positive disease. When you are in later lines of treatment and you need to administer chemotherapy, because if you can administer endocrine therapy, is not such a problem, but if you need chemotherapy, well, in this case, some caution is needed, because the treatment will not save the life of the patients, and the chance that the treatment in later lines of therapy actually induce a prolongation of overall survival are very tiny, are very small actually. So in that cases, you must balance between the chance that you give some more toxicity or an infection that becomes symptomatic from COVID, or you keep your patient in palliative care and you hope that you can resume treatment as soon as possible. It's hard to say, because every decision must be taken in the individual patients. If patients have comorbidities, and this might happen, maybe it's better to delay treatment and to avoid that the patients, if negative, comes to the hospital, and if positive, to give active anti-cancer treatment. If the patient is asymptomatic and without comorbidities, we administer treatment. But the most important thing, in my opinion, is not the oncology team, is the surrounding multidisciplinary teams. Because when you have to do major surgery, you cannot do surgery in these periods in all patients, because the surgical theaters cannot work, because all the other teams that needs to work on a surgery in a cancer patients are on the COVID patients. So it's very difficult. This might have produced some delays, and we will see the impact of these delays in cancer diagnosis and in cancer treatment in the next years and in the next month, possibly. So for what we can do, we should keep our patients on treatment as long as possible and as needed as possible, taking into account that we are dealing with cancer patients that have a life threat from their disease other than from COVID.